There are a few studies in the literature speaking about this problem, and what we know is that upper airway obstruction is frequent, and the only retrospective study showed in ALS patient that actually this is a very frequent problem. In ALS patient, in this study, authors divided the patient according to the oxygen saturation during the night in bad ventilated and good ventilated patient. And they found that bad ventilated patient was 50%, and the most important cause was the upper airway obstruction. So only in this population we have data. We don't have epidemiological data of the prevalence of this problem during non-invasive ventilation, but we perceive that this is really a very frequent problem. Even about this problem, we don't have data about prevalence, but actually the feeling is that the most important cause is what we see also in OSA patient, that is the pharyngeal collapse of the pharyngeal tract collapse, and this is the most frequent cause in neuromuscular and even in COPD patient. Actually, there is another possibility of upper airway obstruction during mechanical ventilation, that is the glottis closure. This is a complete different mechanism and a different site of obstruction that is lower, and it is at the glottic plane, and even the mechanism underlying is completely different. This is a big problem during non-invasive ventilation because, first of all, the second mechanism I explained before, that is the glottic closure, is induced by non-invasive ventilation. So this is one type of upper airway obstruction, more frequently viewed in this patient ventilated by mask. And this is due to the high pressure, the high volume induced by the ventilator. This is a reflex induced by a very abrupt reduction of PCO2 or an hypocapnia induced by ventilation that induce a glottic closure by a reflex. This is one of the most frequent mechanisms of upper airway obstruction induced by non-invasive ventilation, but in the literature some authors describe other mechanisms, like for example some obstruction induced by the use of the facial mask. The oronasal mask, actually, by pushing the jaw, it can induce a drawback of the tongue and the soft palates and induce an obstruction at this level. And this is another mechanism that we should take in account in this kind of patient. And the last mechanism that was described was in some bulbar patient, above all in ASL, a sort of drawback of the epiglottics, and that also may induce an upper airway obstruction. Actually, we don't really know, but we can say that in neuromuscular patient we may have both mechanisms, that is pharyngeal collapse due to the upper airway problem, but also we can have the glottic closure because these patients are well ventilated during the night, and the mechanism of the abrupt decrease of PCO2 may be frequent. So restrictive patient, neuromuscular patient are patients in which more frequently we can see both mechanisms. The use of a flow and pressure curve that we can record with the ventilator, with the home care ventilators, are useful to detect this phenomena, because what we see on the flow curves is that there is a recurrent and abrupt decrease of the flow, which assume also a waveform of a square or a zero flow. That means that in that time there is an upper airway obstruction. So by reviewing the recording flow curve with a windows of 5-10 minutes, we can detect this phenomena. But what this kind of waveform tell us is only that there is an obstruction of the upper airway, but they don't tell us which kind of mechanism is underlying this problem. And in this case, by adding bells, we can have more information, because if the upper airway obstruction is due to the pharyngeal collapse, in this case, we will have a drive active, even more active. That means that on the bells we'll see a movement. Otherwise, if the obstruction is the glottic closure that is induced by hypocapnia and is a reflex of hyperventilation, in this case we will have no drive activity, and so on the bells we will not see a movement of the bells. So the use of the bells is very useful to understand the mechanism underlying. We have to know that the bells are not useful to understand if the other possible mechanism induced by ventilation, for example, the drawbacks of the tongue or the drawbacks of epiglottics, are not well detected by only the bells. In that case, we need video laryngoscopy. Actually, what we have to thought is the mechanism underlying the upper airway obstruction. So, if the mechanism is the pharyngeal collapse, in that case, an increase in EPAP is what we need during non-invasive ventilation to solve the problem. Otherwise, if the mechanism is the reflect glottic closure, in this case, we know that the hyperventilation is the cause, the abrupt decrease of PCO2 is the cause. In that case, we need to reduce the pressure. So the intervention on the setting is completely different. So we have to know this, above all when we decide to use, for example, some algorithm with EPAP, variable EPAP, because in that case, what the software do is only to detect the obstruction. The software is not able to detect the level of the obstruction, and consequently is not able to detect also the mechanism underlying. So useful to use algorithm, but is very important to monitor what we do with this software, because the software cannot be right. Yes, I think that the most important paper where you can find the differences in the traces between the different kind of obstruction could be a paper published by Jesus Bermejo Gonzalez in Thorax 2012. And another important paper, descriptive paper, is a paper made by a group, a Spanish group. The first name is Catalan, and it is published on respiratory care, 2017, and you can find there some video laryngoscopy images about the different mechanisms of upper airway obstruction.